Well, everybody, welcome to an expert talk series. You know that we put these on for you because you're important. And remember, at Everything ALS, we are dedicated to uncovering new discoveries, aiding in early detection. As you are aware, research on ALS by participating, that you can be participating in our speech study. The purpose of the speech study is to enhance the diagnosis and prognosis of ALS. We are seeking participants to provide 5 recordings, each lasting 15 minutes once a month, for a total of 75 minutes over 5 months. I'm sure that would be doable, and if possible, we would really appreciate it. We welcome healthy participants as well as individuals diagnosed or probable with ALS to join us. To enroll, go to everythingals.org/speech project, and you'll find that in the chat. We also have one other study we are actively recruiting for, the asymptomatic gene carrier study. If you're a gene carrier and asymptomatic and interested in remotely monitoring your speech, cognition, and motor skills, please visit everythingals.org asymptomatic study and fill out the form. And you'll also find that link in our chat. And with that, Christian, I'll turn it over to you.
Thank you so much, McFinn. And thank you, everybody, for joining tonight's program. Tonight's program on the East Coast and this afternoon's program on the West Coast, and wherever you're watching on demand afterwards. Thank you for joining. Tonight we have the pleasure of having Dr. Jason Ackrivo joining us to present on breathing in ALS, insights from a clinical research program for respiratory care in ALS. And a little background on Dr. Jason, on Dr. Ackrivo. He's the assistant professor of medicine and neurology and associate director of the J. and Randy Fishman program for home-assisted ventilation, pulmonary, allergy, and critical care division of the Perelman School of Medicine at the University of Pennsylvania. Dr. Ackrivo's clinical expertise includes chronic non-invasive ventilation, home mechanical ventilation, chronic respiratory failure, and respiratory care of neuromuscular disease. Dr. Ackrivo's research has focused on improving the respiratory care of individuals with chronic respiratory failure. And his research has covered topics such as risk factors for and phenotypes of respiratory failure in ALS, and quantifying survival benefit from non-invasive ventilation, and developing novel approaches of telemonitoring home ventilation. Something that's, of course, near and dear to the work that we do here. And just a little bit of housekeeping as we get going here. Dr. Ackrivo is going to provide you his presentation. He will, of course, stay for community questions and answers. So please, whatever questions you have, you can leave them in the chat, and we will make sure that we get to every one of them as time permitting. And so, feel free to ask whenever during the presentation, and we'll get to them at the end of the presentation. Thank you so much again. So, Dr. Jason Ackrivo, you're up.
Thanks so much. Thank you for the invitation. I'll try to share my screen with the PowerPoint presentation. Okay. So you're seeing the full slide or the notes? Somebody mind? Let me know.
Okay. Full slide.
Full slide.
Full slide. Okay, great. Thank you. Okay, so as you heard, I'm Jason Ackrivo. I'm a pulmonologist at the University of Pennsylvania, and I also spend a good deal of my clinical time, not just in the pulmonary clinic, but also directly within the ALS clinic at Penn. Today, I'm hoping to share with you what we've learned over the last several years with our clinical research program focused on respiratory care. For ALS, I don't have any relevant disclosures. These are my current and recent funding sources. So today I'll do a very brief background on how ALS can affect your breathing. And then with that as a background, we'll go into what are some important research questions regarding respiratory care of ALS. And within those, we'll highlight some research studies that we've undertaken and what we've learned. And then at the end, we'll talk about, what have we learned and what's next. So how does muscle weakness affect my breathing if I have ALS or really most other neuromuscular diseases. So I like to break down the respiratory system and the kind of three kind of vital organs of respiration. There's the lungs themselves, highlighted here in purple, and they're primarily responsible for gas exchange. So that is pulling in oxygen and breathing out carbon dioxide. And we'll cover that a bit more later on in the talk. There's the central airways. So that's really their main job is to channel air from the outside world into our lungs and then from our lungs back out to the outside world. And then there's the respiratory pump. So this is the main breathing muscles, the diaphragm, but it can also include chest wall muscles, both between the ribs, above the ribs, in the neck, and also in the abdomen as well. And so if you have a neuromuscular respiratory muscle weakness, you may notice at some point it may become difficult to breathe while laying down. The reason is because, as shown on the left here, our diaphragm wants to move down towards our feet when we breathe in. And when you're upright, as this figure is, gravity helps that. But when you lay down flat, you lose the advantage of gravity, and all of your belly organs pancake out and push up against your diaphragm. And so it makes it harder for the diaphragm to move towards the feet. And so in everybody, it's a little bit more difficult to breathe while you're laying flat, but it's especially more difficult if you have neuromuscular disease that affects your diaphragm. And this can also lead to issues when you're trying to lie flat to sleep overnight. And so some of the symptoms that you might have significant respiratory muscle weakness include interrupted or non-restorative sleep, morning headaches, brain fog, fatigue, daytime sleepiness. You might notice more shortness of breath than usual. As I mentioned on the previous slide, you have discomfort while lying flat. This is the medical terms orthopnea. You may also notice a weakened cough. So knowing that these symptoms are possible, and for all of us with ALS, it can happen at a very variable stage of the disease. It can happen early on, or it can happen relatively later. But if we know in the ALS disease timeline that in general, you have some type of symptom onset, usually followed by the diagnosis, and at some point after that, or maybe even closer to the diagnosis, respiratory symptoms occur. We know that early on, usually a neurologist is going to get involved. But what about a pulmonologist? If we know respiratory symptoms are going to occur, should we wait until they develop before we call the pulmonologist? Should we see how they go and wait to call the pulmonologist later? Or if we know that they're coming, should we call the pulmonologist even earlier? I don't think that anyone really has a good answer, but this is really helps drive a lot of the clinical questions that we're asking for our research. And I put this question in quotes because I actually had this asked by one of my patients early on when I was first thinking about building a research career around respiratory care and ALS. And the patient said, how do I know if my breathing is going to be affected 6 months from now? I don't remember if they said exactly 6 months, but it was some type of timeline in the future. And so I started thinking about how a lot of, especially in the academic ALS centers, where we're collecting this data every single visit, we have these large data sets. What if we had data that was collected at baseline, meaning early on, maybe one of the initial visits? Is there a way we could use this data to potentially foreshadow or predict when respiratory impairment is going to occur so we can anticipate it? If we were able to predict it, this might improve physician-patient communication, timing of interventions, informing patients more about their disease and maybe even empower them, and it might help inform clinical trial design. So what we designed was our main outcome in the research study. We called it respiratory insufficiency. And really how we defined it was any of the following bullet points within 6 months from baseline. So that could be starting non-invasive ventilation, a forced vital capacity falling below 50% predicted, receiving a tracheostomy, or passing away. And so we picked 6 months just because it was more feasible to do that within the data set that we had. And so we had a couple different data sets. We had a long both of these are historical data sets. So one is from the University of Pennsylvania. At the time, it was approximately 10 years worth of data, and we included 765 patients. There's also a larger data set known as the PROACT data set, which is a combined data set from multiple clinical trials. And in this analysis, we included a little over 7,000 patients in our analysis. What we wanted to do was see if we could build what's called a prediction model, where we could use these baseline variables shown on the left here: age, symptom onset site, time between symptom onset and diagnosis, forced vital capacity, FRSR scores. These are variables that are commonly collected in almost every ALS clinic. And so since we thought that these were readily available, we could use these to potentially predict in 6 months from now, could somebody develop any of these outcomes? And the way we built our model was we categorized patients as high versus low risk. So without getting into the details of how the analysis went, we ended up deciding on a cut point of 45%, meaning if based on the model, they were predicted to have at least a 45% probability of any of these outcomes by 6 months, we called them high risk. And if it was less than 45%, we called them low risk. And what we end up doing is we compare what was expected based on the model versus what actually happened. And in both cohorts, a little over a third of patients had this outcome within 6 months. And so when you compare the expected versus the actual observed, you get these figures that look like this, and I'll walk you through it. So on the left, this is these curves here represent how well the model's predicting what actually happened versus what was predicted. The further that the curve gets as close as possible to this top left corner, the better the model is performing. And so we started the model within the Penn cohort, shown in the red curve here. And the result was 0.86, but without really knowing exactly what that number means, it was a pretty good performance of the model. And then to show how good the model is, what you have to do is you take it, you make it in one data set, and then you try to apply it to another data set to see if it still holds. And so we applied it to the PROACT data set, and you can see the curve is lower, but still pretty reasonable. So it's not perfect, but it still had decent performance, and it correctly predicted the outcome in about 77% of patients. As shown on the right here, what we did is we grouped patients by whether they were predicted as low risk versus high risk, and then followed them over time. And the faster that the curve drops here, the faster that group is developing an event. So as you can see here, the predicted high risk group is developing events much sooner than the predicted low risk. You can see the difference in the curves here. So suggesting that what we were predicting to happen on the whole was happening. However, we have to have some caution here. This is all historical data, and to really make sure that the model actually performs well, you need a new study where you specifically design the study to test the model performance. And so that's what we did. We applied to the National Institutes of Health, and we were lucky enough to get a 5-year grant to do a multi-center cohort study where we enrolled patients at ALS clinics in the centers shown here. We called it the Pennsylvania ALS cohort study, or PALS cohort study. And we would enroll patients early on in disease and follow them forward in time and to see what happened. And we haven't published this yet, so this is unpublished data, but I can show you one of the figures here, which is kind of similar to what I showed you a couple slides ago, where again, we're grouping individuals by whether they were predicted to have a low risk or a high risk, and what actually ended up happening. And I hope you can appreciate here that there's a definite separation between the curves here, and suggesting that the model is performing pretty well for most patients where they're predicted to have an event early on, they actually are. It correctly classified approximately 80% of participants. The high-risk individuals had approximately 70% chance of having an event within 6 months. And those predicted to be low risk, only 17% of them ended up having one of those events within 6 months. So again, model's not perfect, but we feel very encouraged by this, that this is a tool that could potentially be used to help have conversations with patients, inform how we enroll patients for clinical trials. We may even be able to build upon this model in the future with additional data. I've also had a similar question from another patient that asked this exact phrase: what is my trajectory? What is it going to be like? He was taking his hands and moving it through the air. What will my trajectory be like? And it got me thinking, is there a way that we could identify different trajectories of different patients, knowing that ALS varies so differently between individuals and how quickly it progresses? What I realized is that we collect this breathing test in clinic about every visit, known as the vital capacity, sometimes called the forced vital capacity, or FVC, or VC for short. And approximately every 3 months, which is usually roughly when the visits are in the ALS clinic, a VC is collected. So we have these VCs that are collected repeatedly over time, as shown here. And this is a graph at the bottom that I just drew arbitrary lines, just trying in my head to think, there may be some people who start off at a certain level and then progress at a different rate than others. How could we group these people? How could we identify who they are? And so there is a certain type of analysis called a trajectory modeling analysis. And the way I try to describe this is it's kind of like how we use a topographical map. So we use a topographical map with all these lines on the page, knowing that the lines aren't actually there in real life, but the lines are there to approximate what you see. And so it's a way of trying to organize a very complex picture into something that might be easier for you to understand. And so what we did is we applied this analysis to the University of Pennsylvania cohort. We had 837 patients. And we found 3 separate groups based on how forced vital capacity changes over time. The first group, shown at the top in green, we called the slow progressors, because the FVC started at a higher number and progressed much more slowly over time, and that represented about 14% of patients. There was another group that also started with a high FVC, but then progressed much more rapidly over time, and so we called them the rapid progressors, and that was about 39% of patients. Then there was a third group that we called stable low, where the FVC was low to begin with, and then it just didn't progress a whole lot more. So we ended up calling it the stable low group, and that represented about 47% of the patients. Similar to our prior analysis, what we did is we built this in the University of Pennsylvania cohort, and then we applied it to that larger PROACT cohort, and the patterns would still hold. We got a very similar result. And what we also asked ourselves was, okay, it's one thing to group individuals by how they progress, but is it actually clinically meaningful? Do they end up having significant events at different time points than others? And what we found is that they did. We found that, as you can see here, the separation in the curves here, which again, the steepness of the curve is equal to how quickly the group is having an event. And so what we ended up noticing here is that the slow progressors, while all the curves are falling, but the slow progressors fall at a much more slower rate than the rapid progressors, as opposed to the stable low. So showing that the groups that we identified did have, significance clinically in terms of how quickly they may progress to a respiratory event, or this respiratory insufficiency outcome. And this, we need more work in this area to be able to identify patients early on as to who's in which group, so that we begin to start having conversations and develop treatment plans. And speaking of treatment, the cornerstone of respiratory treatment for ALS is there's a lot of different terms that people have used. There's home-assisted ventilation, there's non-invasive ventilation, which I often abbreviate as NIV, also called bilevel ventilation or BiPAP, also also referred to as a ventilator. All of these can deliver what is called non-invasive ventilation, where it is pushing air in and out of your lungs, usually through a mask, as shown in this picture. There's a lot of different devices out there. I just chose some random ones here just to show on the screen. Again, I have no financial relationship with any of these companies, just a sample of different devices here. There's also a wide variety of different types of masks that are available out there. We don't have the time today to get into that in much detail, but just to highlight this for you. But knowing that non-invasive ventilation is available, is it actually helpful? Well, there was what we call a landmark study. This was not a research that we did, published back in 2006, where they did a randomized control trial where they took 41 patients with ALS, and they assigned them to one group would receive non-invasive ventilation, and the other group would never receive non-invasive ventilation. So this is a study that will never be replicated. And then they followed them forward in time, and they found that the group that received NIV, or short for non-invasive ventilation, had a longer survival. It also showed that among those who used NIV versus those who didn't have it, they had higher quality of life scores. But the study was published in 2006. It was relatively small sample size, small group. What about some more modern data? Here we are, 2025. The technology for non-invasive ventilation has progressed very significantly since then. If we have more modern data, does this benefit still shake out? And so what we did is we took that University of Pennsylvania cohort, the data set that I mentioned earlier, that 10-year data set. And I was looking through it, and I noticed that there were, this is just a natural history study of what naturally happened over time. And there were some patients that at some point in their disease, they were prescribed NIV, or non-invasive ventilation. And there was other patients who were never prescribed NIV for reasons which we don't know because it wasn't recorded in the data set. But according to the data set, they were never prescribed. And so I thought maybe there's a way here to compare those who got NIV versus those who never were prescribed NIV. And so what we ended up doing was we created matched pairs. So what we did is we took individuals who were prescribed NIV, and at the time they were prescribed, we looked at their characteristics, and then we found another patient in the data set that looked very similar, matched on multiple different variables, so that they were similar disease stage, similar breathing function, and said, okay, well, here's two people who look very similar. One is getting the treatment, one is not. Let's follow them forward in time and see what happened and compare. The outcome in this analysis was survival from the time that NIV was started or they were matched. And so, as I mentioned, this was, really a question of a history study of were they ever prescribed, and then we matched them. It was 10 years worth of data. And through our analysis in this study, we found that individuals who were prescribed NIV versus never prescribed NIV had approximately 26% lower risk of death at any time after they had been prescribed NIV. And then we started asking, okay, one thing to be prescribed, but how do we know if they're using it? Does using it more have any more benefit? And so that's why I started asking, could more hours of use or more consistent use lead to better outcomes? And so we took the group that received a prescription for NIV, and in the data set, the patients were asked, how many hours a day are you using the device? And so this is patient-reported hours, and we grouped them by averages of how many hours they reported over time. And so we had one group that reported using it on average more than 4 hours versus on average less than 4 hours. And again, 10 years worth of data. And we found that amongst the people prescribed NIV, those who were reporting that they were using it on average more than 4 hours per day had approximately 33% lower risk of death at any time after they started using NIV. So suggesting here that It's one thing to be prescribed it, but being consistent with your use, using it more, may also have an additional benefit. Then that got me wondering, okay, well, how do I maximize the benefit? How do, if we know that it's likely beneficial, is there a way to make sure it's helping as much as possible? And this got me thinking a bit more about what is the actual goal of home ventilation. Did a lot of reflecting, and it was hard to narrow it down to just 3. And there may be more on this list, but I was thinking maximizing quality of life, providing a restful night's sleep, and optimizing gas exchange. Is a term I mentioned on one of the earlier slides, where our lungs are responsible for pulling in oxygen and breathing out carbon dioxide. And to help with this third point, measuring gas exchange, we really have to leverage what available technology we have. And to really understand this at a little bit deeper level, I think it's important to understand what is this oxygen and carbon dioxide? How is it important? So I like to just, if you could imagine a gasoline-powered automobile. So put the electric car to the side for a second. Gasoline-powered automobile. We put fuel in the car to make it go. Analogous to that is we put oxygen in our bodies to help our bodies function. And when the car burns the fuel, it makes a waste product that goes out the back, out the exhaust. The same thing with our bodies. When we burn oxygen, we make a waste product. And that waste product is carbon dioxide, or sometimes abbreviated CO2. So it's kind of similar to analogy here between the car and your lungs. So, but if you have weakened breathing, or smaller breaths, or fewer breaths, what ends up happening is you're not breathing out that carbon dioxide as much as you should be. And so what ends up happening is it goes up. And that rise in carbon dioxide is a sign that your breathing is falling behind what your body really needs it to do. If that carbon dioxide level goes high enough, it actually shares the same space in your lungs as oxygen. So if it goes high enough, it can actually cause your oxygen levels to go down. This is important because most medical centers are very quick to always check your oxygen because it's easy to do. It's not always as easy to check your carbon dioxide level. And there's many ways to do it. I wanted to highlight how we've been trying to study that in the outpatient clinic for patients with ALS. So one way to measure carbon dioxide levels is a transcutaneous carbon dioxide monitor. There are other ways to measure CO2. It often involves needles and other special types of instrument that are often very difficult to do in an outpatient clinic. But this machine is a sensor that just rests on the surface of your skin, as shown in the picture on the right. It's painless. It's not affected by bulbar weakness. As you might have noticed, your tests for FBC may be very difficult if you do have some bulbar impairment where you have weakness of the mouth or the throat. You can use this machine to do spot checks, almost like an additional vital sign in clinic. And you can also do it for continuous recording. This is a picture of how it's done. The monitor is on the left, and a person on the right has the sensor on their left earlobe. Notice here that it can also be performed, not just as a vital sign check, but also a simultaneous check of your CO2 and oxygen, even while you're wearing your non-invasive ventilation mask. The sensor can be put on the cheek as well, or the forehead. So there's a lot of flexibility. And so you can wear it simultaneously with a non-invasive ventilation mask. We've had patients in our clinic where we have them on their machine and we're adjusting their settings and checking their CO2 in real time. So this sounds like great technology, but is CO2 level actually important for outcomes? And to begin looking at this, we had to zoom out and we got some help from our friends at the University of Michigan, where they had a 10-year database of patients at the University of Michigan where they collected these transcutaneous CO2 values over time. And these were patients, what they did is they isolated patients who showed up at the first clinic visit and had an abnormal or high CO2, meaning above the value of 45. And they followed them over time, collecting CO2s at every visit. And they looked at survival at 2 years after the initial visit. There was 337 patients in this data set. And I should let you know that it included a variety of diagnoses. So it's not just neuromuscular disease and ALS, but also COPD, emphysema, spinal cord injury, other sleep disorders. So what we did is we looked over time at what ended up happening when they started off with a high CO2. And what we found was there was a survival benefit, not only when you lowered your CO2, but the more you lowered your CO2, the survival benefits seemed to be improved. So show it here. You can see how the more flat curves are the ones where the CO2 was decreased even more, whereas the ones that are falling more quickly, meaning having more events, were the ones where the CO2 is not changed or even increased. So again, this is a wide variety of diagnoses. We're wondering, okay, what if we isolated the patients with neuromuscular disease, or even specifically the individuals with ALS? So there's actually 56 patients with ALS in this data set. And so it wasn't enough data to really do this level of analysis where you have multiple groups like this. But we did ask ourselves, well, what if we just looked at trying to keep the CO2 as close to normal as possible? And so we separated them by whether they were able to get their CO2 below 50, or if the CO2 went in the wrong direction and ended up going above 50. And what we found here, as shown by the separation in the two curves here, that those who would lower their CO2 tended to have a longer survival. We also found that for every 5 units that you lower your CO2, there was a 33% reduction in the risk of death. Now we have to be a little cautious in how we interpret this. Again, this was a historical data set. There, it wasn't one of the studies where you design it for a specific question and follow it forward in time. But this is definitely what we call hypothesis generating, where it suggests that this might be an area of research that we should investigate further to see if there's a real cause and effect here. We have done some other studies with transcutaneous CO2. I unfortunately just didn't have time to get into today. We have had patients and clinicians do CO2 monitoring clinic, have it on their patients as well. And we, perform surveys and questionnaires and ask them, like, what do you think of CO2 monitoring, patients and clinicians? And summarizing our results, that they found it valuable, they found it reliable and meaningful for care. And we also asked ourselves, okay, if you can do a more prolonged CO2 recording, would it be possible to even do it overnight? Because there's a suggestion in the literature that breathing issues in ALS may actually begin overnight before they start, in fact, causing significant daytime symptoms. And briefly, what we found is that, yes, it is possible to do it overnight, but we definitely need to study this more. So stay tuned on as things progress with our program with that. So taking a step back even further, a lot of this seems like, okay, well, respiratory care seems to help. If you do it well, it may help. It's one thing to recommend a treatment, but what do the patients actually think themselves? And this is where we wanted to design a study where the patients were teaching us. And so this was another study funded by National Institutes of Health. It was from patients in that PALS study that I mentioned earlier, the multi-center study. We asked patients if they would be okay doing a approximately 30-minute interview. It's a semi-structured interview, meaning there's this very specific way that you go through a defined list of questions. You allow the patients to answer, and the interviews were all recorded. And we turned those recordings into data. And what we ended up doing is, as someone with ALS, what do you think about respiratory care? And we probed them with a lot of different questions just to see what the responses would be like. And as I mentioned, these were recordings where the transcripts of the recordings ended up being the actual data. So the patient's words teaching us. So we had a lot of different, the data from this was immensely complex. I wish I had more time to get into it. So we had identified a few different themes, which I'll share with you. Again, this is more unpublished data right at the moment. One theme was likelihood of starting a respiratory treatment. If a doctor is talking to you about respiratory care, how would you approach it? Would you be open to starting it? And there were some individuals who were a little bit more hesitant. One quote that I had here is, I would have to do more research. I'm very active. Things that could be coming down the line. That's when I will have to make a decision. And some individuals are more open, saying, I will say probably as soon as possible, even though I'm not dealing with it now, it'd be useful to have it in place when it happens, before it happens. It's going to vary, two very different answers here. Some people being a bit more hesitant, maybe wanting to wait till they cross that bridge when they come to it, versus those who like to be more prepared. We also directly asked about non-invasive ventilation, or NIV, and we got some hesitant answers from some people. Getting used to sleeping with something on my face. I might feel claustrophobic. Thing over your head and the hose and that stuff, I'd rather avoid that if I could. Whereas some individuals were open, saying, I don't think I would turn that down because it's used for a method of assistance and not dependency. We had multiple other themes, and again, I wish I had more time to go into it, but some of the other themes that we identified in the pattern of the patient's answers was refusal of breathing treatments, whether they take a proactive versus reactive approach to their health, meaning proactive, wanting to be prepared, researching everything, trying to have everything in place ahead of time, versus reactive, meaning not wanting to necessarily do all the research. They'd rather address a problem as they arise. We also asked about some individuals who were interviewed actually had already been started on respiratory treatments. So we asked them about their experience so far with respiratory care. We found that the patients had a wide variety of learning style preferences. We also asked about the presence and perceived burden of caregivers and how that affected conversations about respiratory care. So we took all the answers and we came up with several proposed strategies for approaching respiratory care for individuals with ALS. One is assess patient readiness for adopting more information. And I should say that we haven't been able to test any of these strategies yet. They're really more of a proposal. But assessing readiness, because again, as shown by some of those answers, everyone might be at a different stage with how ready they are to start talking about it. But at least early on, you could have the door open to discussing it and bringing it up early in case they want to talk about it. Patients like a variety of different education formats. So having some form of education in a different variety of formats, that might be something they can actually look at and hold, might be something they could read. There's a variety of different ways to help educate somebody in the way that they prefer. And identifying barriers. Some of this is kind of complicated technology. It's not so straightforward bringing that into the home, incorporating that into their daily life. And so identifying these barriers early may help streamline them being able to get on treatment. And after starting respiratory therapy, such as NIV, it's not like a set it and forget it. You really do have to revisit with the patient. How is it going? Are you comfortable? How does it feel? It's really a very iterative process. You have to revisit multiple times before you get them to the point where they're using it well and comfortably. So after reviewing all of that, what's next? What are we doing now? What's coming in the near future? So current or soon to be active studies. So right now we're actually doing a small, we call a single arm trial where everyone's getting the treatment. It's called the MyPal study, funded by the National Institutes of Health. What we're doing is we're introducing what we commonly refer to as the cough assist, and we're introducing it early on before the patients are on any respiratory care at all to do almost like a lung volume. It's called lung volume recruitment. It's almost like a physical therapy exercise for the chest wall to see what effect that has. And we're almost at our target enrollment, so stay tuned on that. We also were lucky enough to recently get funding by the Department of Defense to do a study called the EverythingALS study, where we'll be doing a clinical trial on ideal timing for starting non-invasive ventilation in ALS. We're definitely very much in the planning stage right now, not yet enrolling, but we're hoping to begin this later this year. And then what are the gaps in future directions? So just thinking about how can we maximize our ability to deliver respiratory care going forward. Number one, I think, is education. It's important to educate the patients, but it's also important to make sure that the clinicians, the doctors, the medical teams also understand respiratory care of neuromuscular disease. The technology for non-invasive ventilation and the different respiratory care devices have rapidly advanced in the last handful, 10, 15 years. So it's become a very specialized area of medicine that may not be taught well in doctors' training. There's few centers across the country that really have expertise in this area. I think education would help fuel the pipeline of clinicians who understand this. I know this is a hot button topic nowadays, but this really applies to almost any point in time. We're making sure that people are submitting grants and trying to obtain and have opportunities for funding for scientific research so that we can use what we have to try to maximize the care for patients to help improve outcomes. Personalizing the treatment plans. So, again, going back to the fact that ALS, it's highly variable in how it presents and how it progresses. And that means that there's no one size fits all approach, and that also applies to respiratory care. And I think that we need to understand ways that we can tailor our therapy to the patient's individual needs. And then, as I mentioned in this talk, respiratory monitoring, I think, is going to be critical. There's a lot of advancements, not only in respiratory monitoring with we have the spirometry measuring CO2 values, but also the NIV devices themselves actually collect data that's stored in the cloud on web portals. And that's a mountain of data that we could begin analyzing as a way to try to figure out the best ways to deliver non-invasive ventilation and other forms of respiratory care. So in summary and take-home messages, predicting disease progression would help guide care and research design. There's definitely several unanswered questions for non-invasive ventilation, such as time to start, ways to introduce, how to adjust the therapy. We also want to improve quality of life as well. That's extremely important. Monitoring strategies, there's a lot of different ways we can monitor. It may help identify breathing issues potentially earlier. And they might also help provide treatment targets. Discussing respiratory care is enormously complex. It requires a flexible, well-rounded approach because, again, everyone might be at a different stage with how they want to talk about it. And this is just a plug for what we call observational studies, where an observational study is a study where there's no intervention, no treatment. We're collecting clinical data and following patients over time. And these can be really important because observational studies can help feed really critical information into how we design future interventional clinical trials. So if there is an observational study going on at your clinic, if you feel comfortable, I would suggest you consider volunteering if you can. I just want to go over my acknowledgments. First and foremost to all of you, everyone here that's joining in, taking time out of your busy lives to be here to empower yourself and learn. Patients, caregivers, support teams in the ALS community, those affected by ALS. You folks are the ones that I've learned the most from, helped inform these research questions and helped me really be a better doctor. So thank you. The EverythingALS group for inviting me to be here today. The group where I work at the Penn Comprehensive ALS Center, I told them I wouldn't do this, but I'm putting up a big picture of them just as a thank you. This is an amazing group of people, very inspiring, work together great, and they're very supportive. And I don't think I would be giving this talk today if it weren't for them. So I owe them a lot. The Penn Home of Ventilation team at University of Pennsylvania. Too many people to thank. Different collaborators at different institutions, my research mentor, Steve Kawut, my various funding sources. And that is everything that I have. So thank you for your attention.
Thank you so much, Dr. Ackrivo. Great presentation and really informative. And we got some great questions already coming in for you. So we will dive right into the Q&A, and the Q&A stays open. So please continue to post your questions in the chat while we start to dive in here. I'll do the first question, and our friend Ashir here on the team is one of our student ambassadors is going to help me out. So first question is, what's the best way to gauge nebulizer effectiveness?
Well, it depends on how much you need it. Nebulizers can be helpful for humidifying the airway, helping to open up the airways, and potentially loosening mucus. I would say that not every patient with ALS needs to be on a nebulizer. It really just depends on what's your mucus burden, how much secretions you have. If you don't have a lot of mucus or secretions to get up, it might be hard to tell if the nebulizer is actually working. I also say that in someone who has weakness of their cough, because again, the respiratory muscles that are weak also affect cough. If your cough is weak, the nebulizer is not going to help you cough up any better. And so I often pair the nebulizers with the cough assist device. And so I think that the nebulizers can go in, help loosen things up, open up the lungs, and then you follow it with a cough assist treatment, and that might help maximize how much you can get up. But it's a complicated answer because it depends on how much mucus or secretions you have at baseline at the beginning to be able to tell whether it's effective.
Thank you so much.
Hello. So the next question we have is, do you track vagus nerve atrophy? And what about phrenic nerve atrophy? And could you discuss ongoing research in these areas?
Vagus nerve, I have not. Phrenic nerve, so the phrenic nerve is a nerve that goes down to, that works on the diaphragm, that main breathing muscle. Just in terms of atrophy, I have not, to answer your question directly, I've not tracked it. There was some research that, looked at, not necessarily the phrenic nerve, but the phrenic nerve innervating the diaphragm. And there was a study that looked at diaphragm pacing in ALS, meaning there's like a pacer that helps the diaphragm contract. And it did not show an improvement in outcomes, and the potential suggestion that the outcomes were worse. But beyond that, I'm just not aware of many other studies that are looking at this in terms of the vagus or phrenic nerve.
Thank you. So next question was, I had respiratory onset about 4 years ago, and I've been on NIV 24/7 for the last year and a half or so. How long can this continue? Is there some predictability to that? Yeah,
so being on non-invasive ventilation 24 hours a day, I think is something that, because the technology of the devices has advanced so much, it has become possible to be on non-invasive ventilation around the clock for a long period of time. Whereas I think years ago, that automatically would have ended up, the only option offered would have been a tracheostomy, but you can be comfortably ventilated non-invasively 24 hours for quite a long time. I would say that the barriers to how long this can keep up is one, how good the bulbar function is. If sometimes the bulbar function gets bad enough, it can be very difficult to ventilate non-invasively. Not impossible still, but it's because of the integrity of the upper airway. It can be hard to push the air past, and so it can sometimes be very difficult to ventilate non-invasively if there's significant bulbar impairment. With the bulbar impairment can come aspiration, where you're silently aspirating saliva and mucus down into the lungs, which could potentially turn into pneumonia. So I would say it's dependent on how good bulbar function is, and if there's enough aspiration to start developing pneumonia. When you get if you're regularly getting pneumonia and it's unfortunately having you to go to the hospital, then it starts accumulating where you can get sicker and sicker and harder to recover. So I think it's hard for me to give you a timeline, but things I would look out for are bulbar function, aspiration and rate of respiratory infections. And then the other thing I would say is just your level of comfort. Some people just get used to having a mask on their face all day, and they're fine with that. But there are some people that maybe related to the settings or the mask itself can get quite uncomfortable. And it just depends on if the comfort is impeding your quality of life to the point where it might actually be more comfortable removing the mask from your face, but that would have to be a transfer to a tracheostomy to keep ventilating you.
Thank you so much.
Okay, so our next question we have from another ALS patient. I experienced mouth dryness while using overnight NIV. Use of a xylitol spray has been suggested, but are there other options to reduce the dryness?
Are you using a humidifier? So I've had some patients that are set up on NIV and they did not get a humidifier with their machine. So if it's the smaller BiPAP device, they have a humidifier built in. If it's the ventilator, they don't have, generally, they don't have humidifiers built in. And so you have to have an inline humidifier that's midway between the vent and your mask. And if you don't have the humidifier, I would start with that, making sure you're humidified. If you are using a humidifier, you can actually dial up and down the humidifier setting. If you don't know how to do that, you can ask your, I assume that everyone here is from the United States. We use DME companies to help service these devices. You can ask your DME to help coach you through how to adjust the humidifier setting and try to find, you might need to just turn up the humidifier setting. I've had some patients that even though they have humidifier in line with their ventilator, they still, maybe they open up their mouth a lot at night, they still get dry mouth. And so you can actually get a humidifier for the room. Just, the way you would maybe if when you're sick, you put a humidifier in the room and humidify the entire room while you're on non-invasive ventilation. That can also help with dry mouth. So humidifier, yes, no. If yes, adjust the setting. If you're adjusting the settings, you're still having dry mouth, even though you turn it all the way up. You might need to get a room humidifier.
Thank you. Next question, regarding the group-based trajectory model in the Penn ALS cohort for FVC measurements over time. With that model, would it be useful in segregation for to segregate fast, moderate, and slow progressors for clinical trials?
Yeah, I think that model and the prediction model could be helpful. What's a little tough with the group trajectory modeling is it's a little bit of hindsight is 2020 because you're looking back on the data and seeing who progressed at different rates. But if we were today try to take a group of people who are just diagnosed and say, which group are you in? Unfortunately, that study did not really help us identify which group someone's going to be in. It gave some suggestion. There were some variables that were more prevalent in some groups than others. But we definitely have to do more work in that area to try to identify people, going forward, which group are you in? So that's where I think potentially the prediction model, at least immediately, might be a bit more useful because we can collect the data, put that data into a computer, and it spits out a prediction.
Thank you. And I'm going to jump in front of the next Q&A, and Dr. Ostrow has his hand up, so I wanted to call on Dr. Ostrow to jump in.
So, Jason, so that was fantastic talk, and I'm a huge fan of you and everything you guys are doing, and it's just remarkable. And I have a question, but before I ask the question, you reminded me of something when you mentioned learning from the people with ALS, because I don't know if you remember, about 2 months ago, I actually sent you an email about this unbelievable conversation on an EverythingALS Zoom, where after the expert Zoom in the discussion session, there was this incredibly lively chat amongst the people in the Zoom, or it might have been one of the fireside chats about things that I learned, like things about, a particular IVAPS model that was making noise, and different people who might even be on this Zoom had advice about how to deal with that. And it's just a remarkable way that this community works. But my question is, one of the things that I love about what you guys do is that you're the hands-on, really optimizing and adjusting and teaching people how to do that with lots of different masks, right? And finding masks that fit different people and that they can swap in and out. And my question is, when you have ALS patients, people living with ALS who don't do well with non-invasive ventilation, what are the reasons that they don't do well? And in particular, I wonder if you could comment about secretion trouble, or airway clearance being an issue that's maybe harder. At least it seems, from my less educated standpoint, to be a major problem with people, being able to truly benefit from what you guys do.
Sure. Yeah. And thank you for the compliments. So I think a couple things. Why would somebody not do well in non-invasive ventilation? What I have noticed anecdotally is there's a tendency to put, so the usual progression of how it started is they're in the ALS clinic, you need to start NIV. Let's have a DME company go out to your home and put you on NIV. And what ends up happening is they get put on very generic settings, where the settings are set where these machines, they can have variable pressure and variable settings, and they just set these very wide parameters, and they just say, okay, let's let the machine figure it out. The problem is a lot of the default settings for the machine are actually clearly designed for people with COPD. And this neuromuscular disease is a very different disease to ventilate than COPD. And so often the settings end up being uncomfortable because the pressure's either going very high and very low, up and down very quickly, or without getting into the weeds too much, the setting that is on there is requiring the patient to pull too hard to get a full enough breath. The duration of the breath is just too short. And so often it is just a matter of adjusting the settings, and sometimes just changing the mode is something that would be, in my experience, has been a big reason why people are failing. They're just on very basic generic settings, and it's not actually tailored to them. And once I actually see the patients and adjust the settings, I have no two patients on the same NIV settings. With regards to secretion clearance, really just, as you know, depends on, can matter about how much bulbar impairment they have, the level of sialuria that they might have. If they have sialuria, I'm very proactive about, trying to put them on glycopyrrolate, and, being proactive about their cough assistance, where, making sure that early on, if I can, and the patient's open to it, obviously, is trying to get them on a cough assist device and encourage them to use it regularly. There are some patients that try as hard as you can. You have a cough assist, whether or not you need nebulizers, and you have them on non-invasive ventilation, and it's just maybe mostly because of the level of bulbar impairment. Non-invasive ventilation can be extremely challenging. So we're definitely still learning a lot, but I don't know if I'm exactly answering the question the way that you want me to, but it's most patients we can get NIV to work. Most of the time when it's not working, when they first see us, it's because of the settings, less the secretion clearance. But in terms of helping with secretion clearance, it's addressing sialuria, addressing post-nasal drip. Don't forget about nasal sprays, because that can drip down as well. And then making sure that you have them on their cough assist early and using regularly, because with the weakness of the cough, they can have trouble clearing secretions and mucus, which could turn into infections.
For people who don't like or just can't tolerate the cough assist for whatever reason, do you ever use the oscillating vests? Is there data for them? Are they useful?
Yeah, so I guess going back to the cough assist and how to tolerate it. So it's interesting. There's a study in the Netherlands. Sorry, I forget which country it is in Northern Europe. Tina Anderson, Tina with two I's, N.A. Anderson, did some very interesting studies where she titrated cough assists under camera guided, where she had like the camera that you use for fees going through the mask in the nose down over the vocal cords, and she was directly visualizing the airway as she did the cough assist. And what she found is that in some patients with a certain amount of bulbar involvement, the pressure from the cough assist actually causes the upper airway to close down. It's like a reflexive reaction. And in those individuals, if it's felt that the bulbar impairment is impairing their ability to actually tolerate the pressure going in, they just might be on too high of a pressure. The air is going in too quickly, and it's scaring their airway, and it's causing them to clamp down. So they may actually tolerate the cough assist if the inspiratory pressures. She has a whole protocol in her papers. If the inspiratory pressures are lowered, to actually allow the air to go in a bit more gentle. But if I'm trying the cough assist and I'm going up and down on the pressures and trying to adjust it to their comfort, and they're still just not tolerating it, I would say something is better than nothing, and you could use the vest or percussion vest. Although, again, the vest is not going to help them. It's not going to help strengthen the cough and remove mucus. It just kind of helps loosen it up. So it's a little bit of a different mechanism.
Thank you. Thanks so much, Dr. Oscar, as well, for making sure we got a really good explanation of it. So I'm going to jump ahead as well with some of the questions that we still have. How are upper motor neurons involved in respiration? And did you notice any difference between upper motor neuron predominant patients versus lower motor neuron predominant patients in your research, or even mixed?
I think we need to take a better look at that. I don't think we got as granular as that with our data. There is a suggestion that with significant bulbar involvement, especially early on, if there's upper motor neuron bulbar involvement, as I mentioned, there can be this kind of spasticity of the upper airway, which as a reflex, the pressure that's coming in from these devices can cause the upper airway to reflexively clamp down. And that plus the impaired secretion management can make non-invasive ventilation very difficult to tolerate if it's not set properly. The other thing that can happen with bulbar impairment, or just in general, is if you have a full face mask where the mask is going over the nose and the mouth, and the lower straps on the mask are too tight, it's actually going to push your jaw backwards, and that might actually narrow your airway even further. And so making sure that the lower straps aren't too tight. No, they should be snug, but not too tight. There are some people that actually just tolerate the nasal mask, where it's just pushing air through the nose, better for that reason, because the air just kind of goes down the back of their throat, and there's not any extra pressure on their jaw. But this is a long-winded way of saying I need to look more at the upper motor neuron involvement. I imagine that it does present challenges to tolerating these therapies where we're forcing air down into the airway.
Thank you so much.
All right, so the next question we have from another patient. So they say, my husband had a sleep study done and was found to need 1 liter of O2. When we went to the ALS clinic, they discouraged using O2. Should we do another study and try to find parameter settings that could eliminate the need for oxygen? Or do you have any other advice?
Yeah, great question. I almost mentioned it while I was in the talk, but to remember that if the primary reason that you have low oxygen, assuming your husband doesn't have other types of lung disease, the primary reason that there's low oxygen is because of neuromuscular disease. It may actually just be because he's not moving enough air in and out of his lungs. it may be a CO2 related thing, or deep down in the lungs are kind of squished at the bottom. The medical terms could be atelectasis. And so I think you could alleviate your husband's need for oxygen by just getting him on effective non-invasive ventilation settings and then repeating the test. And if he's on effective enough settings, I would not be surprised if he got completely off oxygen. We've been able to do that in many patients. Sorry, can I just round out my question? My answer to that is just that so if you have a disease like ALS where you're prone to these high CO2 levels, and that's the reason why the oxygen is low, in most medical centers, they're just going to be testing the oxygen. They're not always testing the CO2. And so they see that your oxygen is low and they give you oxygen. But the problem with that is it's not addressing the underlying cause. The underlying cause is because your CO2 is high. And actually giving you too much oxygen can actually trick your brain and your body into thinking, oh, everything's fine. I got all this oxygen. I can breathe normal. And what it actually ends up doing is it causes your breathing to slow down even more. And as your breathing slows down even more, your CO2 goes even higher. So there is a risk of actually getting too much oxygen, especially if the CO2 is high. 1 liter of oxygen is very low, but again, my answer is the same. I would try to get him on effective NIV settings and then repeat the test.
Great. This is actually triggering even more questions from people. We're going to try.
Sorry if I'm going too long here.
No, it's great. I think it's just it just makes folks want to really dig deep into it. So, sure. One quick question is, what FVC score would you say prompts the need for respiratory care or move to NIV?
Yeah, so depends on where you're standing in the world when you ask that question. If you're standing in the United States, you ask the insurance companies. They wait until the FVC falls below 50% before NIV will be covered. They don't specify what type of FVC, meaning you could do a supine laying down FVC, which would be lower. But if you go to other countries around the world and you have symptoms in an FVC below 80%, you can get coverage for NIV, although these other countries tend to have socialized medicine. I would say that if somebody has, I think it depends on the trajectory. If I'm just meeting them and they have a very high FVC, 90%, 100%, they don't seem to have many respiratory symptoms, many issues with sleep disordered breathing. I don't think that at that point I would necessarily be heavily pushing, but it really depends on, if they give me some symptoms that they're having, like the disturbed sleep that I mentioned, fatigue during the day, or their trajectory. So I met them a few months ago, their FVC was 90, but now they're like 72. Okay, well, you're not below the 50, but you did drop. And maybe if I laid you down and checked your FVC as opposed to upright, I may get a lower number. Also remember that if your clinic has the capability, you can do a breathing test called a MIP, MIP, maximum inspiratory pressure, which can also help qualify for non-invasive ventilation. So I think that there's really no specific answer to what FVC I think it should be started. I think, in my opinion, the earlier the better if the patient is willing to do it. I think it depends on the trajectory and if I can get them as close to 50% as possible, depending on positioning, or I might just have to do another test. So they might have an FVC of 70%. I might either do a MIP or have them do an overnight pulse oximetry where they wear the oxygen overnight as well.
Thank you so much.
All right. So the next question we have is, your first study looked at respiratory insufficiency and acute respiratory failure as a combined endpoint. Have you analyzed these separately? And if so, could you discuss a bit further on that?
Yeah, we did. We looked at the different outcomes individually. And we found that overall, the results were pretty similar, especially for the FVC falling below 50 and starting non-invasive ventilation. The tracheostomy event, just, in our data set, the tracheostomy was relatively rare. So we had fewer events, and when you have fewer events, it's harder to really make a meaningful conclusion from your analysis. Within 6 months, the death outcome was also relatively rare, although there was a signal that, being predicted higher risk, the likelihood of death was higher. And we're working on trying to soon submit a publication for the multi-center study where we're showing that the time to each of these outcomes is significantly different based on the prediction.
Thank you so much. Here's a question for you as well regarding just managing an IV. Any tips for managing getting air on the stomach out of the stomach, I think, during an IV use? What causes it?
Yeah, so we call it aerophagia. So you're pushing air in through your nose or your mouth, and it's supposed to go one way down to your lungs, but it makes a wrong turn and goes into your stomach. The first thing I do when that happens is I look at the pressures that you're getting from the machine. So one setting on the machine, it's typically called the EPAP, or expiratory positive airway pressure. This is the amount of pressure that is there between breaths. So it's, you get your breath in and then breath out, and then the pressure that's there between breaths. If that pressure is elevated and you don't really need it, it's possible that's just forcing air down into your stomach. So usually most people with ALS only need a pressure of that about 3, 4, 5. If you're much higher than that, the first thing I would do is lower that as much as possible. If it already is low, then I would look at, how high are the inspiratory pressures that you're getting? Do you really need them? Could you tolerate a slightly lower pressure? And then I would also look at the duration of the breath. The setting is called inspiratory time, but just how long is your breath lasting? Could you potentially tolerate a slightly shorter breath? That might help lessen this from happening. But the first thing I would look at is the pressure between breaths. It's usually called the EPAP. Lower it.
All right, so the next question we have is from another patient. Why is it that I don't feel rest in the morning? I also fight with my mask because my mouth falls open during the night. Could you please provide some advice?
Yeah, so the fact that you don't feel well rested in the morning probably means that the settings that you're getting from your device may not be adequate. But it also sounds like you're having a significant amount of what we call leak overnight, where your jaw's relaxing overnight, it's falling away from the mask. And so the air that's supposed to be going into, your nose and your mouth is just going into the room, and you're having a leak. So it's possible that if you fix the mask fit in the leak, that the settings may be more effective and you can get more rest. What I would do is, so a couple things. If it's a nasal only mask, what you could do is you could try switching to a full face mask, where instead of the mask just going over the nose, it's going over the nose and the mouth. And it might help, even if your jaw opens a little bit, it could help push air through your mouth more effectively. However, some people with a full face mask they still have their jaw relax overnight, and it falls away from the mask. So what I would do is make sure that the mask is put on properly. It's snug and tight. You might start off with the mask fitting well, and then certain positions overnight cause the leak to occur. And unfortunately, you're just going to have to ask a caregiver to help you with adjusting the mask in the middle of the night if you are having this big leak. Another thing that could be tried, there is, if you look up, can I type into the chat? Okay, I'm going to type in something to look up online. Pad a cheek mask stabilizer. So this is just basic, something you can buy online. I think it costs $18, and it's basically a piece of Velcro with a very soft cloth around it, a strap that has Velcro with this cloth around it. You can hang it from the lower straps of the mask. It kind of acts like a hammock, where it goes from one lower strap of the mask to the other lower strap, and it acts like a hammock under your jaw to provide just a slight amount of, support so that your jaw doesn't open up as much overnight. And you can find it online if you Google that, it's approximately, I think it's like $17 or $18. The other thing that is a bit more fabric, but it's called, type into the chat, it's called chin strap. There's a variety of different types of chin straps out there, which you could ask your DME company about. And this is basically a band that goes around your head under the mask that provides a light amount of gentle pressure under your jaw to help keep it in place. You could still talk if you need to, but that's another possible option too.
Thanks so much, Dr. Ackrivo. I'm going to jump into some questions about exercises because there were a few in a row about it. So wanted to get your opinion on doing light abdominal exercises such as crunches or back bridges, sit-ups to maintain muscle tone and core strength. And what your opinion might be about the expiratory muscle strength trainer.
Yeah, this is something that I'm working alongside the neurologists. I've tried to teach myself about and learn from them. My understanding, and this may vary from neurologist to neurologist, but exercise in general is not as a blanket recommended therapy when you have ALS, I guess, because the data haven't shown that it's been significantly beneficial. However, if you feel that it helps in terms of your quality of life, your how you feel during the day and your energy levels, that it is helpful for you. Personally, I think I would just make sure that you're not overdoing it. My worry with neuromuscular disease is if you're exercising, you taking a step back, I kind of think of it as like your any device that you have, your phone or what have you, you have a certain amount of battery level, amount of energy to get through the day. And anything that you do during the day is just going to drain that battery. And it may take you a long time to recover. And so if your exercise routine or the expiratory strength trainer is draining you too much, where it's taking you a while to recover, then you really have to listen to your body and make sure you're not overdoing it. The last thing I'll say is the expiratory strength trainer, I think this was actually studied. There was a randomized trial. I think it was a group in Florida published relatively recently in Neurology. And the expiratory strength trainer caused an improvement in the expiratory strength of one of the breathing tests, but the rest of the outcomes that they measured didn't seem to really change that significantly. So I would have to see more data before I recommend it. So I would say if you feel like it's working for you, but it's not wearing you out too much, okay. But I would just be very cautious about how your energy expenditure is, how much you're budgeting, how much energy you're spending throughout the day to make sure you're not wearing yourself out.
All right. So the next question we have from the audience is, what is your opinion, do you recommend using albuterol or an ipratropium bromide inhaler to help open the lungs and get more out of the cough assistant when there's a lot of phlegm?
If there's a lot of phlegm, then I would say albuterol. It's hard to know if ipratropium added to albuterol, it's usually called the duoneb, is really that much helpful. Ipratropium, if given too much, it might actually dry out the secretions more than what you really want, and dry secretions are harder to pull up. So I tend to just use albuterol alone. Yeah. If the mucus is, if there's enough and if it's thick, then I add on what's called hypertonic saline or sodium chloride nebulizer. That can help. It's basically salt water added to the airway that can help thin the mucus and help pull it up easier.
Thank you. Another one from the audience. So going back to atelectasis, what elevation would elevation of the feet, or atelectasis, would elevation of the feet, lowering the head, or any activities like those help move the fluid?
Atelectasis is really more of like a because you're not taking deep breaths, the bottoms of your lungs just aren't getting as much airflow, and so those areas in your lungs are kind of like a big sponge. Those areas of your lungs are just kind of squished, and it's not opening. So the way to help open up those pockets of lung are, upright posture as much as you can, and reducing atelectasis really to help open those lungs. If you can't, because you're the weakness, you're not able to open up those pockets of lungs on your own. You can get help from something like a cough assist, where a cough assist session, all that positive pressure going down into the lungs will help open up those those areas of the lungs that were closed, and it'll help pop them open and help improve airflow. So I would recommend the cough assist can be very helpful. I don't think that elevating. I mean, you could do different positions in the bed where, if you lay on one side for long enough, that side, the part of your lung that's against the bed will start squishing. So changing position frequently can help. So just avoiding laying on one side for a prolonged period of time can also help, because that'll cause atelectasis as well.
Thank you.
Okay. The next question we have is, do you recommend using a vibrating test to help, or rather a vibrating vest to help release secretions during respiratory therapy before using the cough assistant?
If you have access to both, that can be helpful. What I have found and what I've heard in the United States is that insurance or Medicare only covers one, the vest or the cough assist. If you actually have both, then yes, the order of airway clearance would be, if you need them, nebulizers first if you need them, then the vest to loosen up the secretions, and then followed by the cough assist to pull them out. I've just found that my personal opinion is that the cough assist alone tends to be the most effective because it's weakness of the cough, so it helps pull it up. And I haven't been able to really, just thinking a handful of times I've tried, it's been very difficult to get both of those devices covered. But if you have access to both, then yes, vest before cough assist.
I've got a double question regarding transcutaneous CO2 monitoring.
Okay.
One is, are you prescribing at-home transcutaneous CO2 monitoring for patients on NIV to assist in adjusting therapy? And past that, yes, no, do you also, is transcutaneous CO2 monitoring expensive to the point that, could you ask a clinic to buy one to monitor fellow patients during visits?
Yes, on a very limited basis, we're getting home transcutaneous CO2. The problem is related to your second question. It's very expensive and it's not reimbursed. So we have been lucky enough to have a local DME company that has one of the machines that does it for us on request. But I would not expect that. I mean, you could certainly ask if your clinic can work with a local DME company to try to do this. But it requires them to be willing to invest in the technology. So I think it's hard to make that a blanket recommendation. And then your second question about the expense, that is a limitation for sure that I wish I had more time to go into in my talk. A limitation of transcutaneous CO2 is it's just very expensive and it's not reimbursed. So a lot of clinics just don't have it. And so I think it's going to take, at the present time, very careful discussions with your medical team and your hospital leadership to talk about, why it's important to have something like that. There is a way that your medical team could contact the name of the company The company, it's called Centec. I could put that in the chat. They do have some programs where they have a program where you can do this, get access to a monitor, and they could allow you to have the monitor as long as you're buying the supplies for it frequently enough. But even that, to be honest with you, the costs add up. So cost is the big thing right now. They need a billing code. Maybe some of our research can help them with that, but that's the big limitation right now.
It's certainly a great use of observational data and lived experience data is to be able to advocate for more billing codes for key services. So
yeah.
We're going to have a couple of final questions. One was a clarifying question. So one of our audience members wasn't completely clear on what you said about whether or not it's necessary for one to use oxygen if they have atelectasis. That, just really clear on that. Just is that necessary?
If it's ALS and you're detected to have low oxygen, my first instinct is to check CO2 and make sure that your CO2 isn't high. And even still, I would go on I assume you have an NIV device, or if you don't, I would get one. And I would be on your NIV device as a way to help improve your oxygen. And I would only really consider using oxygen if we're confident that your NIV settings are adequate. And even despite that, your oxygen levels are low, then I would prescribe oxygen. But I rarely, if ever, have had somebody on oxygen alone without being on their NIV device.
Thank you so much. I think we are really at time, but we have time for one final question. I think, Ashir, you had that one?
Sure, yeah. So another question we have is, what does the evidence say about NIV use in acute hypoxemic respiratory failure, for example, ARDS?
Can you repeat that again?
Yeah, we got a question. What does the evidence say about NIV use in acute hypoxemic respiratory failure, for example, ARDS?
Well, NIV use in acute hypoxemic respiratory failure is something that, this is very different than outpatient ALS care. But NIV use can be helpful for reducing work of breathing if the person is what we call hypercapnic, where the CO2 levels are elevated. Non-invasive ventilation can be helpful, but not everyone who has ARDS and low oxygen are the same. There are some people with ARDS and low oxygen, and just that takes a physician, a clinician at the bedside to say, that person looks like they're in life-threatening respiratory failure and they need to be intubated. And I wouldn't even consider NIV. So it really depends on what the patient looks like. How bad is the work of breathing? How low is the oxygen? What's their trajectory like? But it can be helpful. NIV can be helpful in people who have high CO2s. It's been helpful in heart failure. It can be helpful when they come off the ventilator and preventing them from going back on the ventilator. And I'll mention there's a comment by Dr. Ostro. It's really, really good. So I don't want to make oxygen sound like it's always a bad thing. There's a lot of reasons why someone's oxygen can be low. And that's why I kept saying if it's purely because they have ALS, there are definite times when oxygen is necessary. If it is a sudden change, that could be a sign of a possible blood clot in the lungs, such as a pulmonary embolus. If there's a concern for infection, you could have pneumonia. And those would be circumstances where, yes, you should be on oxygen. So I apologize if I wasn't clear. What I was really discussing was if it's, we know it's just the ALS that's going on, maybe a little bit of the atelectasis, and there's just been a slow change in the oxygen status. This is where you should be on the ventilator. But if it's a sudden change in your oxygen status, sudden change in how you're breathing, you need to be evaluated by somebody to make sure you don't have something such as a blood clot or pneumonia.
So much, Dr. Ackrivo. Thank you so much for staying so long with us in the Q&A. We have gone all the way to the full time of 8:30 on the East Coast, and it's just been a really great discussion. Thank you to the audience for so many great questions, and I'm sure there will be many more. For any questions that we did not get to, we'll follow up with Dr. Ackrivo as well and see if we can get just a few quick answers to get back to the audience members through email and when the program is available on demand. It will also be in the mobile app where you can continue to ask questions using the generative AI chat that wraps around every video in our app. So we will make sure that we populate that with the extra questions and answers. Again, Dr. Ackrivo, thank you. Thank you for your time. Thank you for the presentation. And I'm going to give the program back to McFinn now.
All right. Thanks, everybody, for inviting me. It was a great time. Thank you to all of you.
We appreciate your assistance, and we're sending hearts to you because our hearts are big and we want to share them. And for everyone who was here today, we found our family. Thank you all for participating, for being, as I say, joyful that you found your people. And what more can we say except for we're sending our hearts and our love to all of you. And remember, Fireside Chat is 7 days away, and we can all come back together one more time. And with that, Jason, our hats are off. We're not wearing them, but we got our big auras, and we're tipping them to you, sir. Thank you for spending this extra time with us, because those questions just kept coming in, because this is such an important subject. And you're an important...
Well, thank you.
All right.
Thank you to all of you.
All right. Take good care of yourself for us. Thank you.